prior to the EPA pilot, Alicia, what were your impressions of, through your previous experience, workplace-based learning and assessment?
I'd never given it a lot of thought, to be honest. I accepted it as a routine and normal part of being a trainee. I'd always had good feedback. I mean, I've never had difficulties with supervisors or within my clinical terms. But now that I've given it more thought, I look back and realise that I received a lot of general feedback that wasn't necessarily all that helpful. It tended to be nice and encouraging, but not necessarily all that constructive, or certainly not very specific, I think is probably the better way to put it. I certainly found this to be a much more structured program, a much more structured tool that allowed my supervisor to say, you know, at the moment, this is where you are, and I'm hoping that in a couple of months' time, you might progress to this stage. And I'd never received such concrete feedback before. I hope that answers the question.
Yeah, it does. I might pose the same, thank you, Alicia, I might pose the same question to our audience. So this is sort of prior to the pilot. Can you think back, cast your mind back to what life was like then, and your general thoughts about on-the-job training, really, workplace-based learning, supervision, assessment. Can't think back that far? It's only 6 months ago. Yes, Gihan.
Yeah, I've struggled with time-based training, and I think the kind of temptation then is, if things are kind of bubbling along okay, just to let them run, and then you have your end of rotation meeting, and then things sort of fall in the average to high average range when you're working your way down those tick boxes. But I think moving to the EPAs has made us think at the very start about the journey and make sure that we put the steps in place along the ways to make sure that we give ourselves the best chance of getting to a good outcome at the end of the rotation. So that's been very helpful for me.
Nigel, did you want to add something to that?
Well, yeah, I mean, I think it really suited the way that we actually are training people, and I'd come to it from a different view, working with my other hat in a general hospital and seeing general paediatrician trainees coming through with a hugely variable skill set and not necessarily what we need, all of whom had achieved the same level of training. So we might have people who'd done their neonatal training, but their level of skill was hugely variable. Some were very competent at certain technical skills, others are not, which is very important for us in the hospital to know what they're doing. And it surprised me that they could complete that training and be so diverse in terms of their skill set. And when I spoke to the directors of those units, they said, oh, well, that's just the way it is. And to me, that's not an acceptable way to train people to be consultants. And one of the comments was when, for example, I had a lot of our registrars have never intubated a baby after their neonatal intensive care term, was to say to one of the consultants, well, I find this unacceptable. We have 5,500 deliveries in this hospital. They need to be able to do that. And his comment was, no, they don't. I mean, they've always got consultants around. Well, that's fine in the level 3 nurseries, but there are 40,000 other babies that are born in Victoria outside that area. And sometimes you're going to need to have these skills. So it really concerned me, and therefore this was a nice way to set goals and to determine a way of having a consistent outcome and a manageable outcome.
Thank you, well summarised. Do any of the trainees want to pick up on Alicia's comment about the specificity of the feedback?
Yeah, thank you. I agree very strongly with Alicia that prior to the EPA tools being set up, I felt that there was a lot of ambiguity with respect to what I was trying to achieve during the training year and whether I was actually progressing towards a specific goal at the end of the year. With the EPA tools, I think it has given me the opportunity to have direct observation on targeted areas that are more specific and tailored towards community child health training, and to have that area looked at over a period of time towards certified proficiency and competency. So I think that that's really good.
Thank you. I've got another question for you, Alicia. Reflecting probably more on your experience to date with workplace-based learning, and including the tools like the mini CX, case-based discussion, and so forth. So, do you think that type of training has benefited you in your learning and work to date?
I think it has. Mini CEXs obviously have been an ongoing part of basic training, so I'm quite familiar with those. The usefulness of those, personally for me, in the past, I think they're important. Once again, I think the kind of feedback that I've received, even from direct observations with mini CEXs, has been more or less general, and not, you don't walk away with it necessarily with concrete goals for future improvement. But I think that would be hugely variable upon the supervisor and the kind of quality of feedback that they're giving in that particular moment. In general, I think previous tools have lended themselves towards a lot of subjectivity within the kind of feedback that you would receive. Certainly a very motivated supervisor that's very interested in trainee education would probably give you excellent feedback no matter what the tool was, but more time-poor consultants who are, their mind is elsewhere, they're rushing off to emergency, or maybe they would just say, oh, that was lovely, yes, you're a good communicator, and tick, tick, tick. This tool, I feel like, really imposes a structure upon all of the individuals involved, and so it feels as though it introduces more objectivity into the assessment process. I think that you can't completely eliminate subjectivity within the system. I think that that's innate and based on, obviously there's many different personalities involved in a workplace assessment. Some might be more prone to very positive feedback, others might be more critical. Some supervisors are more hands-off, others are more hands-on. But I think that this tool really brings it back to how autonomous can you be at this point in your training within the service, and how much supervision are you still requiring around these different particular tasks. And I think that brings a lot of objectivity into the process.
Okay, so the EPAs have helped bring more objectivity into the use of our pre-existing tools. Okay, is there anything else changed in your view of learning on the job using these sort of competency-based tools?
I think I've had a slightly different experience to some of the other experiences that I've heard about today, where other trainees and supervisors have needed to make very specific meetings with their supervisors and put in a lot of additional time. I think I just happened to already have a lot of that sort of one-on-one feedback time with my supervisor, and that was just the way that he conducted supervision within the service already. So it wasn't cumbersome in terms of lots of additional meetings or additional feedback sessions. We already had those scheduled in, and I'm only a first-year trainee, so I think that my supervisor already is a motivated educator who puts that time in anyway, regardless of the tool. But I can certainly relate to other experiences where that would not have been the case, and can see that this would have benefited me there, where where the onus is on the trainee to approach the supervisor and say, there is this tool that's very structured, it requires a little bit more time and attention than what we've had previously. Would you mind sitting down and working through this with me? So I think in practice for me this term, it's not been cumbersome, but I think if it does require extra time and attention, that's probably a positive thing for rotations where you're not receiving that anyway.
Okay, good point. Now I'm going to throw to the audience again. Just thank you, Alicia, on that, to get your views on that. So again, getting you to travel back in time, pre-pilot, tap back into your mindset then about how you thought and felt and used on-the-job training and the tools, the pre-existing tools, case-based discussions, mini CX, etc. And has that now changed at all as a result of being involved in the pilot? I'll take anywhere from absolutely no change to just life-changing epiphanies.
I might answer that from my perspective. I think, Mick, early on, in many examples, I think we were working in the dark. So unless you actually were observing what people did, you really only had second-hand information, or you were making character judgments rather than actually judgments about people's capacity.
Yeah.
So I think the introduction of all the workplace-based assessment, so gradually, mini CXs and case-based discussions and so forth, have gradually over time increased our capacity to actually assess what the skills of our trainees are, and I think really the EPA tools have increased our capacity one step further. They're probably not perfect either, of course, and it depends how many you do, and over what time period, and how well they really reflect the work we do. But it's a very good start, and I think I'm sure there'll be many more EPAs written over the years as our practice changes, for example, as well, because what we do now may not be exactly what we do in 5, 10, 15 years' time. So we'll need to rewrite them and change them. But I think it's something that's evolved over decades, really.
Do you think that this is a really good, thank you, Mo, really good point. Do you think that this having an EPA-based structure allows that to happen, that evolution? Is it then feasible to, if there's a new area of practice that explodes, like genomic medicine over the next few years, are we going to be able to then rethink our EPAs and rewrite them?
Well, absolutely. I don't see any reason why you wouldn't do that, really.
Okay, thank you.
I might just pick up on something you mentioned there, Murray. I think when you mentioned the impact that a judgment on somebody's character can make upon a feedback, I think that's really important and something I've experienced. I think the best feedback that I've received has certainly been from supervisors that I've got along with really well, and that, from a personality perspective, great feedback from teams where personalities have just worked really well together, and that's important too. I think that the extent to which your character and personality fits into a team is probably important clinically anyway. But I sort of look back and think, was my clinical practice and was my professionalism better in those terms? Probably not. I was liked. Whereas I feel like in this tool, realistically, a supervisor who absolutely adores my personality compared to a supervisor who respects me, but maybe we don't get along that well, that they still are asked to say, to what extent can Alicia do this clinic with this amount of supervision or autonomy? And I think that leads to a more objective assessment of how I'm going than just, oh yes, we like her very much and then she's above average.
Very insightful comment, thank you. So direct observation of performance is a major component of the EPAs, particularly to gather evidence of a trainee's competence at certain tasks. So imagine that's potentially been a little bit different and perhaps intimidating for trainees. In my imagination, I just want to hear what it's like from trainee perspective, having your consultants. How does it feel to perform new stuff, new tasks with your consultant sitting there watching you, either in the room or behind the mirror?
That's a really good question. With Robert, we do school-based clinics together, so at special schools for intellectually disabled children, they're mainly behavioural clinics. And that was really, that's really something that we've done together, so he observes me regularly every week, basically, doing one of those clinics. In that sense, I didn't need to schedule a lot of additional observation because we just happened to be doing that clinic together already. So I haven't had a lot of issues in that regard, but I will say that we have a new consultant who's recently joined the service, and I went from doing diagnostic assessments with a psychologist, and for the most part not observed by my supervisor, to having my consultant sitting in the room watching me do the entire thing. And it certainly is nerve-wracking. I found it a very different experience. I think that probably my performance wasn't as good being directly observed in that sense, but I think that with increased exposure to that, so if once that becomes a normal occurrence, then my performance goes back to baseline. When I'm with Robert in the school-based clinic, where that's just the norm, he's always there, I am not nervous about that. It's not unusual. What my behaviour is completely normal. When the observation is an assessment and you know, an unusual occurrence, maybe there's a little bit more intimidation involved, but not to any significant. I don't think there's a significant impact.
Right. Okay, so the more it happens, the more normal it feels. Probably still a little bit of a nervy edge to it.
Yeah.
Especially if it was all, if you had maybe the thoughts that it was all assessment rather than sort of learning, teaching and learning.
Well,
Would that
that's
be
right. Yeah, that's right. Yeah.
Trainees, what do you guys think? I'd like to pose the same question to you. So how does it feel to perform new tasks, particularly, or tasks particularly new and different tasks with your supervisor directly observing you close by?
I think it might be just a bit more my personality, but I do get quite nervous, and I feel that it's anxiety provoking, especially because, especially if it's not a usual occurrence, if it's specially scheduled and you know it's for an assessment of some sort, and you keep it in the back of your mind that this is constructive and it's feedback, but it's still, you can't help but realize there's an expert in the room who you would try and get information, do history, do your thing your way, but you know that they have a better way of doing it, or they, you know, have a better way of asking the question. They can do it in a shorter time. They're more specific. That, you know, so you almost stop to think before you would, you know, just go ahead and do what you would if you weren't observed. So I think there is that element, but I agree with Alicia that the more that happens, the easier it will get. And yeah, it's dependent on the supervisor as well. So again, there's that dynamic.
Paul?
I kind of agree, like when you're under the pressure and when you're being assessed, you probably don't perform as well as you would have done. So I was lucky, some of our clinics, there's the mirror screen, so you often don't know that they're actually watching you because they've just randomly walked in. So actually we had that, so you'd actually do your assessment, you'd give your feedback, and they can actually watch you without that added pressure that you're getting. So you actually perform a lot better because you don't realise that's what's happening, and that's how you would manage your clinical professional skill anyway, and it gives a better directed observation than actually sitting in and watching. It's not practical in all aspects, but you know, at least when I was coming back to a point when you're getting to that final stages where you're going to be entrusted with something, you know, as trainees we rotate either 6 months or every year. Even if you score you're scoring a high and they think you're got the autonomy, no matter what placement you're going to go to, you're going to go back to being supervised. Even if you've scored really well, done really well in your last placement, your new supervisor still doesn't quite know you, so they're going to want to directly observe you anyway, even if you have that autonomy. So there's a little bit of kind of, even though you're achieving this autonomy, you're ready to go into the next step. You're always going to go back a bit as well.
Mm-hmm. Thank you, Paul. Any other trainee comments?
Yeah, thank you, Mick. I fully agree with all my colleagues, and I must say that even when we talk about being entrusted with a certain domain, I think it's also sometimes case-specific. Gihan's provided excellent supervision all throughout the year, but I know that, you know, there are times I have had him supervise me with probably very complex, say, challenging sort of scenarios that normally I would have maybe handled a bit better if it was in probably a certain context, but maybe with that particular case, all the odds seemed to be stacked against, you know, managing this patient properly, and therefore I could very well at that point in time look like someone that needed full supervision because of the complexity of the case, which my gut feeling would not be very different from a consultant sitting out independently in practice. But for the purposes of that, assessment, that would be the level I would look or appear to be at. So I think that direct observation still needs to be put into the context of what sort of observation is being carried out at that particular point in time.
It's good. I've definitely been in that situation, and probably the first thing that would come out of my mouth is, oh man, that was tough and you did so well, and if that was me, you know what? Yeah, so I think you're right to tap into the supervisor experiencing the stress and difficulties of that situation. What about supervisors? What have you guys noted about, or what are your observations been about this direct observation? Pros, cons? Vanessa?
So I guess from my perspective, I've needed to change a little bit what we normally do. So normally when your trainee reaches that level of confidence, you step back and you're not there anymore. And it's actually that finding time to then go back in and observe someone who you know is competent, who would normally just run a clinic in parallel to you, and you just meet up and have a discussion at the end. That required the organisation and the time, because that was then doubling up in a way that you wouldn't normally need to, or you wouldn't have done previously, because you've got to the point where you feel they're able to manage those things and that they will call you in if they need you. So that was different. Also, this is probably just me, but sitting on your hands in a clinic is really hard. So I did find the mirror really useful, because it meant I would stop interrupting and jumping in when I didn't need to, and actually be there but not be there, because being there and not saying anything when clearly you're the oldest person in the room and everybody turns around and looks at you and you're like trying to direct it back is really difficult. So being there but not being there, which works in the diagnostic and assessment service, it doesn't work in outpatients, and finding it to work in different settings like the school clinics where everybody's used to you being the person that runs it. That's something I feel I need to work on, and also making everybody else feel comfortable for me to step back and let the trainee run it. And I don't know that we've got there yet, but we're working on that.
That's a really good point. I actually think that's a little supervision sub-skill to be able to kind of do that and be the neutral, make yourself invisible but the observer. I was like you, I think, when I first started doing it, but having done it a lot, I'm actually getting much better at that, just sort of shrinking away, and unless there's something crazy or dangerous said where you just have to, you're sort of thinking, okay, well, I'll have to do that right now, or can I actually come back to it and we can fix it up, redirect later in some way that doesn't upset the child, affect child and family's care. But yeah, it's a bit of a sub-skill. We don't have as many mirrors, so we've kind of had to do the sort of garden gnome in the corner thing.
I certainly find it challenging taking a developmental history in conjunction with another doctor. So when you're sort of both firing questions at the family and not necessarily on the same track at exactly the same time, that's been one of the challenges of having a consultant directly involved right next to me. But it's still a valuable experience, definitely. And another point that Vanessa raised about doing clinics, such as school-based clinics, with a consultant, that's been a normal part of my role since I started. I think that it was actually probably the EPA tool that encouraged Robert and I to use that time more productively. So at the start of the rotation, and appropriately so, I assisted him, and he really led the clinic. He led the questioning, and he led the discussions, and that was appropriate. Obviously, I was new. But I can see from other school clinics with other trainees that pattern has continued, and it's easy to fall into that a pattern where that's the way things run, and so it continues in that way. Whereas with the introduction of this tool and Robert saying, oh, well, I observe you every week in this clinic, so okay, next week, let's see, I'm going to watch you run it. You do the questioning, you do the discussions, you lead the management suggestions at the end, and that may have happened anyway, of course. I think in time, hopefully, that's a natural progression. But this tool certainly put the onus on us to focus on that and to start that process perhaps a little earlier than might have happened naturally. So that was a really good thing.
Yes, Gihan.
I think, Alicia, your point about normalising the observation is really important. So I think that's an essential part of the discussion at the front of the EPA pathway. And the other thing I really found helpful is when Viola led the process. So instead of me as a supervisor saying, okay, next week I'm going to come and observe you do something, when Viola said, next week I'm planning this to get this family back for our office-based intervention, can you just come and watch me and then we'll have our feedback discussion? That was really good because it was initiated by Viola and there was a purpose in mind, and she knew what she was going to do, and then we could talk about it afterwards. I think those two things, the normalising and then having the trainee leading the process, makes it a much less intimidating or awkward situation.
And did the having the EPA, so Viola, so you, obviously a very proactive trainee anyway, but did the EPAs help with that sort of setting up of, okay, Gihan, I want you to watch me? Did that make any difference either way?
Oh yes, absolutely. Because in contrast to just doing a mini CX, for instance, where I knew I was just going to be signed off for that discrete mini CX and it would be taken in isolation, oftentimes I tried to get Gihan to pinpoint how I was progressing in certain professional and clinical skills each time he observed me. So there was a continuum, which I think is very important when we're talking about levels of proficiency and competency.
I might make a comment on a couple of things there. I've been trying to do the direct observation for quite a few years and probably just started doing it rather clumsily, I would say. I think the cohort of trainees when I started had not had much experience with mini CXs. So suddenly I'm sitting in the room with them saying, righto guys, I'm observing you, not much workup, and I noticed that over the course of 12 months there was a period of the anxiety levels went sky high and then gradually sort of improved as the year went on, and it was found to be a very useful experience. So every year since I've done it a bit smarter, I think, and one of the key thing is marketing it as normalising it, so this is what we do here, and it's actually because we think this is a really good way for you to learn and for us to teach. So it's all about that, it's all about the teaching and learning. And also the trainees are now coming through have had a bit more experience with actually people directly watching them, you know, maybe not necessarily always in a very targeted way, but at least they've had the experience. So it's getting, every year it gets easier. Our last question, Alicia, is how about, so that's with the consultant sort of sitting there watching you. Well, we want to contrast that with when they're not there. What's your experience of your experience of that? So sitting at a new task, tricky stuff maybe, big new things, and the consultant's not around to observe you.
A good example would probably be around the pharmacotherapy in behavioural paediatrics. So at the start of the term I had essentially no experience, maybe some minuscule awareness of the issue, but certainly no experience. And so, you know, quite appropriately, I think I set a goal that I would increase my knowledge. You know, I wasn't aiming to be, you know, prescribing unsupervised, but you know, it was an area that I wanted to learn more about. As the term has progressed, and I've realised that as a fellow, I receive a lot of inquiries from families about dose titration of various drugs and things like that. The EPAs have sort of led to Robert and I having a lot of really useful discussions about the extent to which he wants to be directly involved in those inquiries and discussions. So, for example, you know, if a family are contacting me because of behavioural escalation and wanting a review to look at, you know, multimodal strategies to address that, including medication, I would certainly involve my supervisor in initiating medications. Families who have been on for example, risperidone for a long period of time and are quite comfortable with it, and are asking if they can go up by 0.5 of a milligram at night for a week. At the start of the term, I didn't know if that was the kind of decision that I could make independently and just sort of let Robert know about it later, or if I needed to really involve him heavily in those kind of decisions. And I think that that would vary based on who your supervisor is. Some supervisors would probably want to be involved in any medication change and any dose titration. But this tool allowed me to have that conversation with Robert to say, you know, at what point do you want to know about what's happening with this? I mean, at the time, and which decisions would you entrust me to make and then let you know about later? So those were the kind of discussions that we were having, and certainly, you know, so that everybody is relieved, I do certainly involve Robert in essentially all of those kind of discussions. But it led to some really useful concrete discussions around to what extent he would trust me to make those kind of decisions. I hope that answers the question.
Yeah, I heard, tell me if this is right, so maybe having the more specific guidelines, performance indicators in the EPAs helped you with your setting it up in advance and your consultations along the way, rather than perhaps being stuck in a clinic presented with a prescribing issue and then sort of thinking, oh no, what do I...
Yeah, I think because we had sat down and looked at that EPA, and I had sort of said quite up front, I don't have experience in this, I'm not asking to be level 4, level 5 or even level 3, I just would like to be exposed to this and learn more. It led to him saying, oh well, you know, you've been involved in these clinics for 6 months now, you are quite knowledgeable about you know, at least a couple of the medications that I'm regularly prescribing, so I would trust you to make small dose increments or small dose titrations over the phone with families, and then get back to me later and let me know about that, and obviously have a follow-up plan. Yeah, I assume that in other contexts those kind of discussions would probably happen anyway, but certainly in my case, this brought those discussions out earlier on and really gave me a clear idea of how much supervision Robert wanted me to be having around very particular issues. So that was really good.
So supervisor, I'd much rather be having that conversation than the one that follows on from, and I put the risperidone dose up to 10 milligrams.
Yeah, yeah. I did that, I hope you don't mind.
Audience, same, compare for the trainees, really, your experience of doing new things, even unfamiliar things, without being directly observed. What's your experience of that been during the pilot, and has having the EPAs influenced that in any way?
I think generally a good supervisor, a good trainee, they're good. That's what they are. So it's really looking at the sort of trainees that may be struggling as well. You need to think about that you know, you need to direct or be observing them a lot more. In most of our clinics that we do, you get supervised at the beginning. When you start a new placement, you're always going to be supervised because they're still getting to know you, you're still getting to know the system. But it's good to know, I don't think the EPAs actually help guide that so much. Like when a supervisor is confident that you can do a clinic or do review things independently, they will let you do that. And I think I think the EPAs give more structure to it. But I think a good trainee is a good trainee, and then you will automatically entrust them to do stuff, I think.
Just reflecting on it, so if a good doctors still result from our training program, but I think a message in there was it helps formalise it, make it a bit more targeted, maybe value add, and potentially even more value for the trainees who are struggling a bit.